Right, so we're recording now. Welcome to the November Liverpool Dementia and Aging Research Forum. Sorry, I have to keep on admitting people. It's fantastic to have James Watson here today to present to us. He's been one of our PhD students and he's in the final stages of his PhD now. I'm sure he's really excited to get rid of his thesis as well at some point soon. So today, James will present an overview of his PhD from the University of Liverpool, looking at inequalities in healthcare use in dementia. And he's really been using a lot of large data sets and big data. So it'll be really interesting to hear about his work, although I'm clearly biased because I'm one of his supervisors. But it's really a nice opportunity for everyone to ask questions to James and really have a discussion afterwards as well about this topic area, which I sometimes think is kind of the best bit of this webinar, having these discussions. So as I just mentioned before, we are recording this. It will be shared on our NIHR ARC Northwest Coast YouTube channel afterwards. And please feel free to post your questions throughout because we will pick them up afterwards. Okay, so just pop them in the chat function. Also, if you are using social media, please feel free to use the hashtag Liverpool Dementia simultaneously, and we can engage there as well. But now, James, over to you. So you should be able to share your screen.
Yeah, I'll give it a go.
Yes. So yeah, floor is yours, James.
Lovely. Right, so I shall make a start. So as Clarissa mentioned, I'm James Watson. I'm a PhD student based at Liverpool University. I started in September 2019 and hoping to submit my thesis early in the new year. As Clarissa mentioned, today I'm going to try and cram my PhD into about 30 minutes of talking. So go through the aims, who I am, what I've done, the research we'll put together, as well as the impact and integrative nature of the PhD and the research from it. So I'm based in the Geographic Data Science Lab in the Geography and Planning Department at the university. However, this is an interdisciplinary PhD, meaning I have a few amazing supervisors, including Clarissa, who have helped me throughout and still do. I'm funded by the Engineering and Physical Sciences Research Council, which is part of the UKRI, and I'm linked in with the ARC Northwest Coast, and I'm in the university's doctoral training network for technologies and healthy aging. Initially, my PhD had a much wider focus. However, on exploration of the data we had from the Clinical Practice Research Data Link and through discussions with my supervisors, it was evident we needed a more defined research topic. So we agreed focus would be on socioeconomic and geographic inequalities in health and health outcomes among people living with dementia. So why is this important? Well, there's more people living with dementia than ever, as we'll all be aware of. And within 2 years, there's projected to be over 1 million people living with dementia in the UK. The greatest increase in the population is expected to be among those with more severe dementia. This greater, more acute need will increase cost and pressure on health and social care services, as well as a greater pressure on informal carers. However, government promises to provide greater funding for dementia have not yet been delivered, and informal carers are already paying more out of pocket for social care than ever. With a lack of forthcoming funding, this is likely to increase the cost to the individual. Inequalities already exist for people living with dementia from diagnosis throughout their pathway. And in the years to come, these inequalities, combined with a likely increased pressure on even more limited availability of services, will likely exacerbate inequalities and result in poorer outcomes. With that said, it's vital to understand the extent to which a variety of factors currently produce inequalities among people living with dementia in their use of healthcare and their health outcomes. We hope the research produced through my PhD will go some way to demonstrating the extent socioeconomic and geographic factors can impact healthcare use and mortality in dementia. So a bit about my PhD. In essence, my PhD has been split into 4 primary research papers. I'll go into some detail a bit later on about all these different papers.
James, just a few comments from the attendees here. I'm not sure whether you're moving your slides or also have it in presenter mode because we still see your title slide.
Okay, so is it stuck on this?
Now we see the breakdown of my PhD.
Right, okay.
But it's still not in presenter mode, so.
Okay. Has that worked?
No.
Okay, I'll stick with, can everyone see this?
The breakdown of my PhD?
Yeah, with the full slide.
Yes.
Is it easier to just stick with this and run through it that way?
Possibly, yes, but yeah.
Okay. I'll stick with that then.
Okay.
So like I said, I'll go into some detail about all these papers, but the first was the systematic review we published in 2020. This looked at how researchers used routine data to explore inequalities in healthcare for people living with dementia. So routine data is basically any like standardized data sets already collected. And so it requires no further data collection. So the records collected and held by GPs or hospitals, for example, they are routinely collected data sets. The next paper, we used GP data to explore the risk of mortality among people diagnosed with dementia based on socioeconomic and geographic characteristics. The third paper published, which I'll also go on to discuss later on, looked at the extent to which socioeconomic and geographic factors impact the use of primary and secondary healthcare services. I'll also discuss briefly at the end the study we're currently working on, which involves developing and understanding similarities in healthcare use over time between people living with dementia and how different pathways through healthcare over time may impact risk of mortality. So, as I mentioned, the first step was to understand what the current literature in dementia inequalities could tell us. Specifically, we looked at how researchers have applied routine data to understand inequalities. To do this, we conducted a systematic review into the subject. I'll go a bit into the process and what we found now. So even researchers with experience of conducting such reviews need guidance on the process. As this was my first such review, and as the primary author, I definitely did. For this, we used PRISMA guidance to develop, maintain, and produce our review. PRISMA defines basically an evidence-based set of items required in the reporting of systematic reviews. Early in the process, researchers need to apply to register their systematic review. Prospero is the international register for such reviews, and they decide on whether it will be added to their register. So we put together our proposal and submitted it to them. This was a somewhat exhaustive process and involved completing a long form to demonstrate the strength, validity, and rigor of the review. This is done through stating the objectives, the intended process shall follow, and who will be involved. This document becomes your protocol and enabled us to refer to a document to make sure we were abiding by the aims and process we defined in the application. So with that said, it was important to define the criteria through which we would search electronic databases. In our case, we wanted to highlight the current literature, and so limited our search to only papers published from 1990 onwards. We also defined specific search terms to make sure we were only drawing from the relevant literature related to the aims. We searched 7 databases, finding initially 800 research papers. At this point, I suppose you could say the kind of real work began. Both Clarissa and I looked through the abstract of each of these almost 800 records. We were looking to see if they met the proposal criteria in the aims of our project. If they didn't, they were removed. This collaborative process resulted in 113 papers being still in the paper at this point. We then independently reviewed those 113 papers in their entirety, reading from cover to cover. The aim was the same, to see which ones met the study aims and were relevant. Irrelevant ones were then removed. We were left with 46 papers to be included in our systematic review. And from this point, it was about understanding what those 46 pieces of research told us about health inequalities for people living with dementia. How could we make a clear picture of it? So first, we defined the overall papers, highlighting the countries they were conducted in. Next, we generated a series of themes that came from the evidence. These themes highlighted the areas in which inequalities were observed, including transitions into nursing care, the use and appropriateness of anti-dementia medications, interactions with health and social care, and finally, the progression of dementia, mortality, and survival among people living with dementia. So the existing evidence emphasised some inequalities in dementia, from diagnosis to accessing and receiving appropriate care, good quality healthcare, to transitions into care and survival. There were differences by socioeconomic and geographic groups. So now I'll go into the specifics. Firstly, the evidence highlighted that deprived areas had a greater need for emergency healthcare. This could potentially be due to later diagnosis, resulting in a greater likelihood of emergency healthcare presentation at a point when a person's condition may be less manageable in the community. Secondly, we noted that people living with dementia from ethnic minority groups were more likely to have dementia, but less likely to be diagnosed. Diagnosis can act as a gateway to care, and a lack of a diagnosis means no treatment or support. As a result, someone's condition may progress at a faster rate, leading to more acute need earlier on. Thirdly, we demonstrated gender, education, age, and living alone independently impacted dementia care. This can be explained through numerous factors. Firstly, the availability of informal care and the societal expectations of women in the caregiving role can have an impact. Health literacy and the burden of caregiving can also impact the utilisation of care and treatment and how somebody's dementia progresses. Faster progression into more severe symptoms can also result in greater, more acute need, which can in turn result in more transitions into nursing care and increased risk of mortality. So from this study, we illustrated the inequalities impacting people living with dementia globally. However, it was also evident from this review that there are limitations in the current literature base. There was a lack of research looking at healthcare as a pathway or a series of connected events. Research instead is focused on individual parts of a person's journey with dementia. There was also a dearth of research looking at more than one or two socioeconomic or geographic factors in inequalities. This review helped us to identify the current literature and demonstrate the gaps in the research. From here, we devised a plan to fill these gaps in the literature. We sought to understand to a greater degree the extent of inequalities in health outcomes and healthcare use among people living with dementia. As I mentioned, through the systematic review, we highlighted a few things. One of those was the lack of research using routine data sets to explore the simultaneous impact of multiple socioeconomic factors and geographic factors on mortality risk. This study aimed to address this gap by employing the CPRD data, which I referred to earlier. There were almost 135,000 people diagnosed with dementia included in our data. They were registered with GPs in England and were diagnosed between 2002 and 2016 and had at least 2 years of healthcare use data beyond diagnosis. The variables we used as our explanatory factors for mortality risk variation were age at diagnosis, let me move that out of the way, age at diagnosis, sex, ethnicity, deprivation quintile, urban-rural GP classification, and GP region. For each person, we also included their yearly rates of 3 primary healthcare types. So the rate of GP observations, the rate of dementia and non-dementia medications. For our analysis, we split our population and had concurrent analysis based on dementia onset. So one group with early onset and another with late. From that point, we conducted Cox proportional hazards regression to assess any variations in mortality risk. In our early onset sample, we found limited differences in mortality risk. However, we did note that men had greater mortality risk than women in our early onset group. In late onset, however, we found several differences in mortality risk. In terms of healthcare use, greater use of dementia medications and increased contact with GPs resulted in a higher risk of mortality. In terms of socioeconomic factors, we again found that men had higher mortality risk than women. In addition to this, we found that people living with dementia from ethnic minority backgrounds had lower mortality risk than people from white ethnicity groups. Each year of age resulted in an increase of 4% greater risk of mortality. People from the most deprived areas had a 20% greater risk of mortality than those from the most affluent. And with the Southeast Coast as our comparison group, risk of mortality was significantly higher in South Central, Southwest, and Northeast GP regions. But what do these results mean in reality? Well, initially we'll discuss deprivation, a factor I imagine people would assume is linked to poor health outcomes. But why is that the case? And why is the variation in mortality risk so stark in people with dementia? Firstly, in areas of greater deprivation, there are greater rates of undiagnosed dementia. People from deprived areas also tend to receive less and more often inadequate care and support. These factors can lead to issues in receiving timely and effective treatment. which can in turn result in faster progression of dementia into more severe symptoms, greater need and use of acute healthcare, potentially resulting in higher mortality risk. Next, we noted people with dementia from ethnic minority groups had lower mortality risk. This finding is a bit more nuanced, but is similar to UK-wide findings. Generally, life expectancy is higher for ethnic minority groups compared to white ethnicity groups in the UK. These findings are seen as reflective of numerous cultural and demographic factors. Firstly, people with dementia from ethnic minority backgrounds tend to be younger when they're diagnosed. Secondly, though the UK population is aging, the demography of ethnic minority groups is younger, which could create a greater pool of people who are able to provide informal care and support. This would enable people to be provided care for a home for longer, a factor which is known to improve survival in dementia. This can go some way to explaining the differences in mortality risk we noted by ethnicity. We also noted variation in mortality risk by geographic region. Geography can be another extremely complex factor to unpick in health outcomes. Large differences in funding and service availability can be seen across relatively small areas. Deprivation is also inherently tied into geography, often with a north-south divide in England and the UK. Though included as a factor in our analysis, it's difficult to account for small pockets of deprivation. We noted higher mortality in the central, southwest and northeast GP regions. The northeast in particular contains some of the most socioeconomically disadvantaged areas in England. The northeast also has greater ill health and the lowest life expectancy of any region in the country. These factors will have played a part in the northeast's increased risk among people with dementia. The south central and southeast regions, however, are relatively affluent. However, they do have an older and less ethnically diverse population. An older population will have less mobility and less access to informal care. This means it's both further to travel and more difficult to access the services needed. This would likely result in less frequent primary healthcare use, poorer condition management, reduced treatment, faster dementia progression, and greater risk of poor health outcomes. The final point to note here is the variation in mortality risk we found based on healthcare use. We demonstrated that some increased primary healthcare use resulted in greater risk of mortality. This leads to the question, what does appropriate primary healthcare look like in dementia? Well, different dementia subtypes, as we'll know, require different treatments and different medications. As a result, delays in diagnosis or incorrect subtype diagnosis can result in inappropriate treatment. People with dementia have greater comorbidities, and one health condition can often take precedence over another. This means instead of being treated holistically, one condition may go undertreated compared to others. Inappropriate treatment and healthcare can impact the speed dementia progresses. More severe dementia can result in greater need and higher use of acute healthcare and risk of mortality. Finally, from this paper, following on from our findings and discussion, we were able to make a few recommendations. Firstly, we stated that older communities need greater support and treatment. This includes both medicated and non-medicated treatment for both dementia and comorbidities. Secondly, for people with dementia and their carers, we needed to improve access and support in using health-enabling technology to promote good health among remote populations. Thirdly, person-centered care is vital, with pragmatic care discussions with the people involved. And finally, support for underserved and disadvantaged groups is essential. Better care can be improved through greater provision of services and better continuity in primary and post-diagnostic services. And the final point to make is one which will lead nicely to my next slide. We noted the need for greater research into healthcare use among people living with dementia, particularly how is the level of healthcare use impacted by socioeconomic and geographic factors. With that said, I'll now discuss this most recent paper published from a PhD. This paper explored how healthcare use varies by the same socioeconomic and geographic factors as previously. We used the same population as the previous paper on mortality risk, again stratified by dementia onset. We used the same group of socioeconomic and geographic explanatory factors for our outcomes. However, in this paper, we had 6 healthcare use types as our outcome measures. These included the 3 primary healthcare measures we've already discussed, so GP observations, dementia medications, and non-dementia medications. We also had 3 secondary healthcare use types. These were A&E attendances and both emergency and elective hospital admissions. For the primary healthcare measures, we conducted models based on the rates per year that people went through. There were, however, a significant enough number of people who did not have each of the 3 secondary healthcare use measures. Therefore, for secondary healthcare outcomes, we conducted regression models as to whether the person did or did not experience the healthcare type. So whether they did or did not attend A&E, for example. We conducted linear regression models for early and late onset populations separately. From our analysis, we illustrated a lot of variation in healthcare use. I'll discuss in turn each result and why this may be the case. So firstly, men have more medications for comorbidities than women. This could be explained as a result of greater and more severe ill health among men. Men also have shorter but more frequent admissions and readmissions to hospital than women. Our second primary finding was variation in healthcare use by ethnicity. Compared to people from white ethnicity groups, people with dementia from ethnic minority groups had greater use of primary healthcare, but were less likely to use emergency healthcare. This could be due to several things. Firstly, people from ethnic minority groups, as we discussed earlier, tend to have greater and more severe comorbidities. This could increase the need for GP contact and the need for medications. Secondly, the demography of ethnic minority groups tends to be younger than white ethnic groups. The greater informal care availability combined with reduced dementia severity may result in less acute health need. Our third finding emphasized the variation in healthcare use due to increased deprivation. People from the most deprived areas saw their GP more and had more non-dementia medications. They also used emergency healthcare more, but had fewer dementia medications. Bear with me because this is a lot to unpack. With that said, people from deprived areas have less access and tend to receive poorer quality healthcare. They also tend to be diagnosed later and have poorer general health than those from affluent areas. Later diagnosis and poorer healthcare can result in faster progression into more severe dementia, which in turn can lead to increased use of acute healthcare at an earlier stage. And greater ill health can exacerbate need and make caring for them at home more difficult. The final main finding was the differences we found between people registered with urban and rural GP practices. People with rural GPs were more likely to attend A&E but see their GP less. This is another factor we need to unpick. So in rural areas, there may be a greater sparsity of healthcare services. And due to this increased remoteness, there is a greater reliance on family members for care and support. There is also a greater reliance on primary healthcare to act as a gateway to post-diagnostic care. If somebody receives poor or ineffective primary healthcare in rural areas, it may mean greater delays in diagnosis or in receiving the appropriate treatment. From these results, we propose several recommendations to impact inequalities in healthcare use. Firstly, we discussed the need to avoid potentially costly healthcare use. The use of secondary healthcare can be financially costly to health and social care, and it can also be detrimental to the health of the individual. To legislate for this, early identification of dementia is vital and can give a wider range of treatment. It can also improve the ongoing management of the health of people living with dementia. Secondly, there's a need to make health and healthcare more equitable. There is a need for better continuity in healthcare and more seamless transitions in healthcare. Stronger links between primary healthcare, post-diagnostic services, and social care can benefit this. Further to this, medicative and non-medicative treatment for dementia and comorbidities needs to be more easily available and included in care discussions with people with dementia and their carers. The final recommendation from this paper was related to the potential for further research. We understand that healthcare use is not a series of individual one-off events. Healthcare use is a pathway, and it's an ongoing series of linked events. This has led to the paper we're currently working on, which I'll now give a very brief description of. So the paper we're currently working on will hopefully highlight how the changing use of primary and secondary healthcare services over time can impact subsequent mortality among people living with dementia. So firstly, we've defined our healthcare use measures, and like defined in previous papers, we've looked at GP observations, dementia medications, non-dementia medications, and an all-encompassing secondary healthcare use measure, which includes both A&E attendances and admissions to hospital. Among the people living with dementia in our data set, we are looking at how their use of healthcare changed over a period of 5 years post-diagnosis. We have started to identify groups of people with similar patterns in healthcare use. We intend to illustrate the different patterns in healthcare use to show the different ways people living with dementia interact with healthcare. From these healthcare patterns, we can observe the differences in socioeconomic and geographic makeup of these groups. This can indicate how different social and geographic groups interact with healthcare over time. Beyond the 5-year period of healthcare use we are looking at, we will also explore how people differently experience mortality risk. So how those different groups, how their risk of mortality varied. I'm hoping to be able to update people on that in the new year. And one last slide, don't worry, I won't be too much longer. I just want to finally discuss how I found my PhD and kind of the process I've gone through. So firstly, apologies for there being so many pictures of my face, but be assured I dislike it as much as you do. But there is a reason for it. So during my PhD, I tried to increase awareness in a way, and particularly discuss my research to highlight the importance of research into dementia and inequalities. Both informal and formal events have given me the chance to talk to a range of people, including those with a vested interest in dementia and research, and people with potentially less knowledge of dementia or less exposure to research in dementia. I've been incredibly lucky to be able to present my research at various conferences across Europe, from those focused on dementia and Alzheimer's to those with other early career researchers, including Alzheimer Europe and the event at the Florey earlier this year. I've also tried to discuss my PhD, my research, and what doing a PhD has been like for me. I've been able to do this through writing blog posts, both on the university website and in my blog posts with the Dementia Researcher Early Career Research Network. With all that said, although it's my PhD, in theory, it's been a collaboration between a lot of people, and I'm lucky to have had wonderful supervisors, including Clarissa. I've also benefited a great deal from working alongside a lot of other data science PhDs in my department who've helped me along the way. It's also been incredibly beneficial to work with more experienced researchers on other projects and to discuss research with other PhDs. I've been incredibly fortunate to meet and work alongside members of public organisations as well, including people living with dementia, their carers, and representatives of people living with dementia, as well as health and social care staff. All of the relationships I've made have helped illuminate the importance of research, and particularly in incorporating the people experiencing what we are researching. So that's me. Thank you for listening to me ramble on, and if I can answer any questions, I'll do my best to.
Right, thank you so much, James. How does it feel to put your PhD into a 30-minute talk?
Difficult and scary at the same time, I think.
It's a friendly audience, so don't worry. So that was great, thank you. You've got lots of feedback already about this. I have shared the link to your systematic review, but we will share the links to your other 2 papers which you've published. So you have been incredibly busy, and I think it's always good for PhD students to try and publish and share whatever they found. It's not just about publishing in academia, but trying to make that impact that you were saying, James, whilst you're doing a PhD, as opposed to let's write a big book and then we do something afterwards. So you've done that really nicely, I think, so far. So put in your questions into the Q&A, everyone, please. So let's pick up on some of the, so there was a question I noticed from Jackie at the beginning. So James, were there any inequalities identified due to dementia subtypes?
Unfortunately, within our data, we weren't able to look into subtype of dementia. The research does emphasize that there are differences just because of the inherent nature of the different types. So whether that be due to the different symptoms that people exhibit or feel during different types of dementia. funnily enough, hopefully that will be one of the ideas of a plan for a next project. If I was able to move into a position where I could do it, that would be really interesting, alongside a lot of other things. I think it seems to be a big melting pot in my mind at the minute as to what could be done next. But that's definitely one area I'd love to go into.
And I think one thing to pick up on here as well, it is incredibly important to look at dementia subtypes, but having used routine data myself from the US, for example, and from England and Wales, we often notice when we use routine data that professionals don't necessarily enter the subtype of dementia sometimes, so there can be a lot of missing data. What has been your experiences with that, James?
Yeah, I suppose routine data it's collected as a catch-all. It's not intended for one researcher's specific project. So, and it is there to keep an audit trail rather than for research purposes in some cases, I'd argue. So it's incredibly useful. If you can find the things you're looking for, then you're very lucky. But there is a degree of what can we gain from this data and what could we look to the future to collect our own primary data as a result, if that makes sense.
Yeah, absolutely. I think you're putting it right. It's one way of looking at things and then to generate more ideas for research and understanding things better, isn't it? So nice question from Laura, who's also finishing up her PhD at the moment. Was there anything that surprised you in your finding, James? Anything unexpected?
One thing we didn't find, to be honest, the first paper we did around mortality risk inequalities, I was surprised that there wasn't a difference between rural and urban areas. That was something that I'd imagined would have come out of it, just because there is a greater sparsity, there's a different age breakdown of the populations, there's further to travel, less, as we showed, less use of primary healthcare services. So that in itself, that people didn't use GP as much when they're with rural GPs, but didn't endure worse mortality risk. That in itself, I think, is something to try and kind of unpick to understand why that's the case, why their mortality is no worse for having less services.
And one question from Sandra, you talked about GP practice in rural and urban, which is kind of picking up on this. But this has now become an issue across both regions with regard. Sandra, do you want to elaborate on this? I can see you on the screen there.
Yeah, I was just picking up on what you were saying about rural and urban, and we're saying that, even people within urban areas now are having difficulty with GP access, and so people that are in urban areas maybe thought they would get this better service because of being in an urban area rather than rural, but that's not really the case. And I was saying, has that come out anywhere?
We've not looked for that specifically, but I'd imagine that is the case with less and less services available and less time for those services to access them as well. Even transport to get to places is an issue, not just in rural areas anymore.
But I'm not talking about sort of the access to, to get to the GP. It's actually getting in to see the GP in the first place. And I think that's where we're sort of like looking now of saying, well, actually, whether you're in rural and you can't get to it, you may live down the road from your GP service, but you still can't get to it. Yeah, so those sort of inequalities are coming across for the people with dementia. They're saying, I live down the road, but I might as well live 100 miles away, because it doesn't make any difference. And that's what the point I'm trying to make.
Yeah, I suppose we can see that a bit as well with, it seems to be a slower transition than you would have thought away from virtual GP appointments back to face-to-face as well. Which obviously there's a cause for both. Like, some people will benefit from having consultations from home. But if you want to go in and access your GP, it seems more difficult than ever for anyone to try and get in, and no one wants to wait an hour and a half in the morning on the phone from 7:30 to then be told, oh, we've got none left, phone up again tomorrow. It's not something we looked into specifically, but equity of healthcare access is something that clearly is an issue, and it's becoming a bigger issue for everyone. So it's definitely another area to look into.
I'm glad you used the word equity. Thank you very much, being from the HEMS team.
And I think also what you're saying about how important the healthcare usage is, if we can try and link up better social care with healthcare, then we can reduce unnecessary healthcare utilization. We can improve the lives of people living at home or in care homes by using better social care support. So that's important as well. Dorcas has her hand up, and then there's some other question.
Thank you so much, Melissa. Clarissa, I've already put it in the chat, please. I put the questions in the chat.
Yes, but would you like to, as you're now here, do you want to ask a question?
One of the two questions is the first one is about the number of the early diagnosis, the number. Were you able to identify the number of those that were diagnosed earlier, especially among ethnic minorities?
So in our early onset, do you mean the split by onset? So there were approximately 4,000 people with early onset dementia, and the majority, around 135,000, had late onset dementia.
Okay.
In terms of an ethnicity breakdown, there were very few. You're talking less than 200 for Asian, Black, or mixed / other ethnicity groups. So it was difficult to bring anything out of it, even though we had a relatively large sample. It's still difficult because there are those small numbers.
Small number. Thank you so much.
No, it's okay. Thank you for the question.
The other question is about, you mentioned about Northeast, South Central. Where are they? Where are they?
So the NHS, in terms of regions, is split up into areas of England. So the Northeast kind of covers Newcastle, Middlesbrough, that kind of area in the northeast of England. The Southwest is, as you'd expect, towards the point of the southwest of the country. And South Central is the middle of the south coast below London, if that makes sense.
Yes, so not around Merseyside. You didn't look at around Merseyside.
So Merseyside is included in the northwest, but there were no significant findings that we found from those. I've just highlighted the ones that we have got significant findings from.
Thank you so much.
No problem.
Great, thank you very much. Are there any other questions from anyone? I think, James, as well, I know you'll have to be grilled by a research panel in a few months' time, don't you, to defend your thesis?
Yeah.
So I think this is a very friendly audience to ask some non-methods questions about where do you take your research next as well, and what does it actually mean?
So I hope to keep in the same area, to be honest. I'm hoping to continue in research and kind of build on what I've done before and work with more people. I've been speaking to different researchers kind of globally, trying to pick their brains and see what they think are the important next questions in dementia research. I'm sure I'll be picking your brain at some point, Clarissa, and everyone here, to ask for ideas. But yeah, trying more so than any other area, I feel like it's important to try and have an impact. Even as a PhD, when you might sense that it's kind of, you're still a student, it's important to try and have an impact, to try and get your research out there so that people can understand what's going on.
Yes, and this is one way, so that's great. And I see actually a lot of carers here on this seminar today, so that's fantastic. Sandra, final question or comment?
Sorry, James, I was just going to say, one of the words that's always used around sort of ARC is about implementation and dissemination. So that's something that you'll probably be getting asked about. Yeah, okay, you've done this research.
Yeah.
So your next steps are, so have you got any ideas or plans about your, sorry to say this to you, but your implementation and your dissemination? We're just trying to warn you for your panel meeting, as Clarissa says.
Yeah, so the overall thesis, I think I'll be able to draw out more pointed conclusions and recommendations, which I would hope I'd be able to take to clinicians themselves. And because my thesis is more based around healthcare and healthcare use, it feels like a natural place for it to speak to clinicians in hospitals, in primary care, in frailty clinics, etc., to try and demonstrate that this is what's happening, like, nationally, and try and engage in a discussion about what could be done rather than just forcing something upon them, because the practicalities of making changes might be a lot more difficult than a research paper might make it sound. So yeah, I know Asan Akpan's one of my supervisors as well, and he's a great link into healthcare, and he's a great work colleague in himself. So speaking to people like that and trying to understand what could be done would, I suppose, be the next step after the thesis.
One just other quick comment is, remember, as public advisors have got sort of lots of contacts.
Yes.
And the reason we're public advisors is to help you researchers. So, you know, and I know you won't be, but don't be afraid to ask for, do we know anyone, and can we help you, you know, get into whoever you need to sort of, you know, disseminate this work.
Definitely.
And you can use that as one of your other pointers as well.
Yeah.
You will work closely with public advisors.
Yeah. And I hope you won't regret saying that, because I will ask you.
I've worked with Clarissa too long to know this now.
Sandra! Publicly recorded webinar. Oh,
Thank you.
oh, that's great. That's a good point. And I think we always talked about the co-production work as well, didn't we, James, where to take that next.
Yeah.
Yeah. So thank you so much. There's a couple more things. So first of all, fantastic presentation, James. You've got a lot of positive feedback in the chat function as well. And maybe I've learned from a separate webinar, if we can all maybe use the clapping hand function to just say, well done, James. I'm going to use that now because we can't see each other. So that'd be a nice way. There we go. Well done, James. And now, just finally wrapping up this, I'm going to share with you the talk that we are going to have at the next event. There we go. And display settings. There we go. Changing this. So in the next year, in the new year, on the 25th of January, we will have a webinar talk by two dementia and hearing loss researchers, Dr. Dalia Tsimpida from the University of Liverpool and Dr. Eitner Heffernan, if I pronounce that correctly, from the University of Nottingham. So they're both doing complementary research on the link between hearing loss and dementia, who is listening. And we will also have a carer who is a public advisor who will join the second aspect of this talk. So it'll be a really interesting focus and topic, and it was generated by the survey we sent out on the Dementia Forum, because lots of you were saying you'd like to hear a little bit more about hearing loss and dementia. So if you want to sign up, here's the link, but I'll also share this after the talk. So now I'm going to stop sharing and just say thank you everyone for joining, and hoping to see you in the new year. Okay, bye everyone.